Welcome everyone. Thank you for tuning into the webinar about Pioneer Phase 2 study of IMO 8400 in dermatomyositis. The webinar is presented by the Myositis Association and Idera Pharmaceuticals. We expect it to take about 45 minutes and we'll have time at the end for Q&A. My name is Kate Ty. I handle site engagement and patient recruitment at Idera. Before we begin, we wanted to run through a few disclaimers. Idera is a publicly traded company, and as such, we're required to disclose that today's call may make forward-looking statements about our business. These are subject to risks and uncertainties that are described more fully in our public filing with the SEC. Also, our presentation today is not intended to provide medical advice, so any medical questions that you have should be addressed directly with your care team and your provider. Today's call is going to hopefully achieve three objectives. The first is to tell you a little bit more about the collaboration between the Myositis Association and Idera, specifically about advancing treatments for dermatomyositis. The second is to tell you a little bit more about IMO 8400, which is the investigational medication that Idera is studying in this phase 2 study for DM. And the third is to tell you more about that study, a study that we've named Pioneer. So to give you a bit more information, I'm going to turn it over now to Bob Goldberg, the Executive Director from the Myositis Association. Go ahead, Bob.
Thank you, Kate. I want to welcome everybody to the webinar. And the organization has been very much involved with Idera over the last probably 2 years now, as Idera was looking toward starting this trial. And I know many of the Myositis Association patients were invited to have input into the process, and through a number of meetings and some focus groups that we conducted at TMA's annual conference, I know the Idera staff took to heart the suggestions that our patients made, and those suggestions have been inputted and have helped shape the trial that Idera is about to get underway. Additionally, we've assisted Idera with the development of their expert advisory board. Many of TMA's medical advisory board members also are serving on Idera's advisory board for this trial. And they bring a level of expertise that really is outstanding. And I just want to thank Idera for inviting TMA and its members to be part of the process, and I know this trial is going to be conducted professionally and will be handled in a way that is most compatible for the patients who participate. So with that, I'd like to turn over to Jim Baker at Idera.
Thanks, Bob. My name is Jim Baker. I lead market development here at Idera. I've been working in rare disease drug development for nearly a decade, and particularly in neuromuscular diseases. And the folks that are also from Idera on the call today, Dr. Kirsten Gruss and Kate, who just spoke, also have tremendous experience in rare diseases as well. And we're supported by an experienced and dedicated team here at Idera, including research and clinical leaders at our offices in Pennsylvania and Massachusetts. And the company has a long history of scientific leadership. And we've developed a proprietary drug discovery technology that targets immune proteins called Tolllike receptors. And we're going to talk about that in a little more detail in a few moments. But we have been using this technology to really focus on developing new treatments for rare diseases like myositis and for cancer as well. So as Bob had mentioned, we first began to explore development of a new treatment for dermatomyositis more than 2 years ago. From the beginning, we knew that we had to work closely with the myositis community to design the best possible clinical trial for patients. So we established a partnership with TMA and pulled together experts in myositis from all over the world to help us design this trial. And we're so grateful for all of their assistance and from the assistance of patients who provided input on many aspects of the trial as well. And we're excited to share with you more details about this clinical program today. And to get going, I'd like to turn it over to Dr. Kirsten Gruss.
Thank you, Jim. Welcome, everyone. So what exactly are Tolllike receptors? So these are receptors that we all normally have in our body, and they are designed to recognize pathogens. So pathogens being bacteria or viruses. And we have specific Toll-like receptors to different parts of these pathogens. So we have Toll-like receptors that recognize the covering of bacteria, and we have Toll-like receptors that recognize the nucleic acids, otherwise known as DNA or RNA, that pathogens can produce as they rapidly replicate. As we all know, a cold virus can certainly do. And these Toll-like receptors recognize these foreign pathogens, and then as the graphic shows, they send a signal to tell our immune system that we are now invaded and we need to produce inflammatory proteins and inflammatory cells to come in and clear up the pathogen. So this is how Toll-like receptors should normally work. However, on the next slide, you'll see that just with the regular wear and tear of life, we all have a little bit of damage to our skin cells and muscle cells, and that's expected. And when these cells are damaged, some of them die and then they're replaced. And in the process of the cells dying, they can also release nucleic acids, so the DNA and RNA that I spoke of. And then this is where things start to go awry. So this DNA and RNA that's from our cells in our normal wear and tear of life actually gets recognized by these Toll-like receptors as an abnormality, and the Toll-like receptor gets turned on. Subsequently, the Toll-like receptor sends the alarm signal so that cytokine proteins are triggered to promote the inflammatory response, triggering the cellular immune system, such as T cells, that will then invade the tissue, such as skin and muscle and dermatomyositis. And then this will cause infiltration of immune cells, abnormal damage to the muscle and the skin, and become an autoimmune condition of these tissues. So what evidence do we have that the Toll-like receptors are bad actors in dermatomyositis? Well, there are certain Toll-like receptors that appear to be overexpressed in the patient's muscles. So these patients often have muscle biopsies that are performed by the experts to make a diagnosis. And when experts have went back and looked at these biopsies, they've demonstrated that Toll-like receptors are abnormally present on the muscle when they shouldn't normally be. In addition, Toll-like receptors, as I said, they send the signal to produce cytokines to trigger the immune system. And one of those specific cytokines is known as interferons. And it's been described that interferons are abnormally produced in patients with dermatomyositis in both their muscle and their skin. And then furthermore, even more evidence, these abnormal cytokines of interferons are correlated to disease activity. So the more abnormal cytokines that are produced in patients, the more active disease patients have in their skin and muscle. And this has all been described by experts in the field. So that leads us to what is IMO 8400? So IMO 8400 is a synthetic oligonucleotide. So it is made up of a small sequence of DNA, and it specifically binds these Toll-like receptors to shut the Toll-like receptors off. So it blocks this abnormal signal that the Toll-like receptors are sending to produce cytokines and an immune response when they shouldn't be. It's administered via a injection into the skin. We call these subcutaneous injections. It is an investigational medication, so it is not approved as a therapy. It has not been approved by a regulatory agency as a therapy. So this is the background where we think that this is a investigational medicine that may have potentially turn off this abnormal pathway in dermatomyositis. So that's why we're proceeding to conduct a study to see if this hypothesis that antagonizing Toll-like receptors may possibly modify the disease in a good way in dermatomyositis patients. Thus far, IMO 8400 has been studied in about 100 patients as of September 2016. So that means that IMO 8400 was initially tested in healthy volunteers at small doses to see if it's safe and tolerable, and then it subsequently moved forward in higher doses in patients with disorders. So some of these patients have disorders of autoimmune disease. Other patients actually have a type of lymphoma. So in lymphoma, patients can have cells that go rogue, and these cells divide uncontrollably and create the lymphomatous type cancer. And specifically lymphomas where B cells abnormally divide and end up causing trouble. there also appears to be a possibility that these Toll-like receptors being abnormally turned on might be part of the overactive drive of these B cells dividing in lymphoma. So moving on to the next slide. With that background, we've also tested IMO 8400 in another autoimmune disease called psoriasis. So psoriasis is a very well-defined autoimmune disease, predominantly of the skin. It's very common. In fact, you may know a family or friend who have psoriasis. They unfortunately get these big red plaques and sometimes a silvery sheen over these plaques that involve a lot of their skin. From a clinical trial standpoint, the amount of skin that's involved can be measured by an established endpoint called the Psoriasis Area and Severity Index, or the PASI. We conducted a very small trial in psoriasis patients with IMO 8400, primarily to look at safety and tolerability. But interestingly, some of these patients had a reduction in their skin disease as measured by PASI over time when they were exposed to IMO 8400. So we felt that that was telling us that we're moving in the direction of knowledge that TLR antagonism may be a good thing to try to target in autoimmune disease. Subsequently, we engaged a lot of experts in the field, as mentioned before by the prior speakers, in dermatomyositis. And with the knowledge that Toll-like receptors appear to be bad actors in dermatomyositis, and with the knowledge that was supplied to us by the experts that a lot of patients struggle with dermatomyositis and that they continue to have active disease despite available standard of care therapy, we thought this was an excellent opportunity to proceed with testing IMO 8400 in dermatomyositis patients in our Pioneer trial. So with that, we'll move forward to describing the Pioneer trial. It is a phase 2 double-blind placebo-controlled trial. So what that means is both the patients and the investigators are blinded or masked to the treatment assignment. So they don't know if the patients are receiving the investigational study drug or placebo. We are looking to enroll 36 patients across 22 sites, predominantly in the US, but we also have a few sites in the UK and Europe. Patients will be randomized to, in a 1:1:1 fashion, to 2 different doses of IMO 8400 or placebo. What that boils down to is that patients who are enrolled have a 2/3 chance of receiving investigational study drug and a 1/3 chance of receiving placebo. The study drug is administered as an injection under the skin that's administered once a week by the study clinic or study nurse. On the next slide describes some of the key basics about the inclusion-exclusion criteria of patients with dermatomyositis who may want to participate. So the age range is fairly broad. It's a range from 18 to 75. The next 2 key factors are that patients do need to have evidence of active skin and active muscle disease. In addition, we know that patients who have active disease can't be completely untreated. So we have specified a specific amount of background immune suppression therapy that they can be on and still have active disease and participate in the trial. So specifically, that fixed dose of background therapy would include a dose of corticosteroids, most commonly known as prednisone, a maximum of 20 milligrams a day, and 1 additional other non-steroidal immune modulatory medication, which includes IVIG, methotrexate, azathioprine, and several others. So as an example, a patient who has active skin or muscle disease and is on a prednisone dose of 20 milligrams a day and IVIG could be screened for potential participation in the trial. However, if a patient was on prednisone of 20 milligrams a day, IVIG, and mycophenolate or Cellcept, they would not be able to be enrolled in the trial. they would have to discuss with their treating physician if they felt that they wanted to proceed in the trial, and if they did, they would then have to discontinue and gradually taper off one of the non-steroidal immune modulatory medications, being either the Cellceptor IVIG in that specific instance as an example. In terms of key exclusion criteria, patients should not have received rituximab or antimalarials in the past several months prior to the screen. In addition, we do know from the experts that patients can also have involvement of some other organ systems outside of their skin and muscle. So patients can have involvement of their lungs, often described as interstitial lung disease. As long as they don't require supplemental oxygen, they can still be included in the trial. We also know from the experts that patients can have some involvement of their swallowing muscles and have some difficulty swallowing, known as dysphagia. Patients can still participate as long as they do not have severe dysphagia requiring a feeding tube. Also, patients should not have any evidence of required treatment for cancer within the past 5 years, except for 2 relatively mild cancers listed on the slides of a non-invasive cancers of the skin or cervix in women. So what are we studying in this trial? So our primary objectives is to assess the safety and tolerability of IMO 8400 in dermatomyositis patients, and to see if IMO 8400 is associated with an improvement in the active skin disease. We're measuring the active skin disease with an instrument called the Cutaneous Dermatomyositis Disease Area and Severity Index. So that's a mouthful. We often refer to it as by the abbreviation CDASI. The CDASI was designed by Dr. Victoria Worth, a renowned expert dermatologist at the University of Pennsylvania. She and several of her colleagues have published quite extensively on the CDASI, in that it can adequately define active skin disease in patients with dermatomyositis. It can define the activity over time. It is a fairly simple one-page instrument that care providers can perform to ascribe a point system to the patient's abnormal skin activity. And most importantly, changes in the CDASI score. As the CDASI worsened, that correlated with the patient's quality of life. So as skin activity got worse, patient's quality of life would, also got worse. So this provided confidence that we knew that this instrument is very robust in defining patients' active skin disease and dermatomyositis, and is our primary outcome in the study. In addition, as you know, skin is not the only organ system affected in dermatomyositis, so we also have a few additional outcome measures to assess muscle. Patients are probably quite familiar with having their strength testing performed in the clinic, and we have a standardized way of assessing strength with something called the manual muscle testing that the experts have been using for some time. In addition, we added some newer assessments, so these are called functional tests. So to look at how strong patients' legs are, particularly the referred to as their proximal legs. So some of our biggest, strongest muscles are up around in our hips. And these time function tests can really measure how well those legs work for people, measuring how quickly they can perform a 10-meter walk run, perform a timed up and go, which is getting out of a chair and walking 3 meters and coming back to a chair, and how well they can climb 4 steps. In addition, we'll follow laboratory tests looking for the level of those inflammatory cytokines in their blood. And at the beginning and at the very end of the study, we'll perform 2 small skin biopsies to look at the histology of the skin over time, and also see if those abnormal inflammatory markers in the skin are changing over time in patients on IMO 8400 versus those who are in the placebo group. And lastly, most importantly, we have a couple measures to ask the patients how they're doing. So the experts have informed us that patients can have a lot of difficulty with itching. So we are very aware of the difficulties with itching that dermatomyositis patients face and how this can impair their life. So we have a very small 5-question 5D itch scale that we'll ask the patients to complete throughout the study, as well as a standard assessment of overall quality of life and functioning called the SF-36. So what should patients expect if they decide they want to proceed into the study? Well, the first thing that generally happens is something called a pre-screen evaluation. So patients who know about the study and are interested, and they may, and their doctor is not necessarily an investigator in the study, they may discuss this with their investigator or with their doctor, or may decide on their own that they want to participate, and then they would subsequently contact a clinical trial site. And there's in the subsequent slides, we'll provide more information about how to do that. So what the patient should do is gather up all of their medical records, so specifically hard copies of their medical records in terms of the diagnosis of their dermatomyositis, any testing they had relative to muscle biopsy or MRIs or CK enzymes or EMG tests, also any recent laboratory tests that their doctor may have performed, particularly their muscle enzymes. Gather these all up, and if they want to proceed with this pre-screening evaluation, and it's okay with the patient, then they'll send these medical records to the clinic coordinator at a investigator site. The investigator will be in touch with them over the phone. They may ask them more questions over the phone. They may also ask them to come in for a clinic visit for evaluation, and then depending on the evaluation of their medical records, they would then decide to proceed forward with a screening visit. At the screening visit, the first thing that happens is an informed consent. An informed consent is very important. It's the document where the investigator tells you why we're doing the study, what to expect in the study, the procedures and tests that you'll undergo in the study, any potential risks to you of participating in the study, and how we will best monitor you and mitigate any risks. In addition, it'll provide you very specific information with all of the tests and procedures that you would be asked to complete during the study. Also, very importantly, there'll be a review of the medications that you've been taking in the past couple months, as it's very important that patients are on a fixed dose of background therapy before they go into this trial. And the reason for that fixed dose is so that we can tell what IMO 8400 does relative to no IMO 8400 or a placebo in these patients over time. So we have a knowledgeable aspect about what this investigational medication does relative to a fixed dose of background therapy for patients. So if the background therapy went up and down, then it would be difficult for us to be able to say with certainty what the investigational medication does. After the screening visit, if the patient completes all of the inclusion-exclusion criteria, they will then proceed forward with the baseline vision or randomization. One key thing on this slide is that the screening evaluation doesn't necessarily take place at a single visit. There's actually a screening period. So in some instances, patients may have to have some additional testing performed before it can be determined if they're eligible to participate in the study. And that screening period can be as long as 28 days to be able to get all that testing done, although it certainly can be much shorter than 28 days. So once patients meet all the eligibility criteria to participate, they will undergo a baseline visit at week 1. So this is the longest visit in the study. So you would plan to spend the day with your clinical trial site, at which point you'll have a comprehensive physical examination, documentation as to how bad your skin disease is by the SIDASI, your strength, the time function tests of your muscle activity, comprehensive laboratory evaluation, and some additional labs to look at inflammatory cytokines and markers in your blood. And then after all of that's completed, you'll have the first administration of your study drug. Thereafter, things are much more condensed. The study drug is administered every week. It can be administered in the clinic or at your home, and then you return to the clinic every month. And when you return to the clinic at monthly evaluations, you undergo a full physical exam, a laboratory draw for safety labs, as well as assess how you're doing, and have repeat testing to look at the activity of your skin disease and muscle disease. And then finally, there's an end of study visit that's performed 1 month after study drug has been discontinued. It's just a final safety evaluation after study drug has been completed. The next slide shows the schedule of events. So as I spoke about, there's the first column is the screening visit. So that essentially assesses your eligibility for the study. that you meet the inclusion-exclusion criterion, specifically that you do have active skin and muscle disease. The next visit is the baseline visit, which, as I said, is the most comprehensive visit. It is also the visit where the skin biopsies take place, in addition to all of the safety labs, full physical exam, and all of the efficacy evaluations of your skin and muscle. Thereafter, the study drug is administered every week, as you can see all of the X's in the row at the bottom, but you only have to come back to clinic every month. If you and the study site are comfortable with proceeding with home visits, you can have the study drug administered between those every month clinic visits in your home. The only thing that takes place at those visits is administration of the study drug. You get your blood pressure and pulse checked, and they ask you how you're doing and review what medications you're on. So they're quite short, but that's up to you and the investigator. They can be done in the clinic or in your home. Oh, sorry, in the clinic, yes, or in home. So at this point, I'm going to turn the slides over to my colleague Kate Ty, who's going to discuss how to participate.
Thanks, Dr. Gruss. So on this slide, you should see a listing of the U.S. sites for Pioneer. These are sites that are either active or planned here in the U.S. There's a full listing of them on the right. You're also able to access them through clinicaltrials.gov, Idera's clinicaltrials.com website, and there'll be more information on how to access that at the end, as well as through the Myositis Association. So you'll notice that there are sites that cover the entire country. They were chosen based on feedback from TMA Expert Advisory Board, from TMA staff members, from patients, and from leaders in the dermatomyositis field. So we did our very best to pick a site near you. If we didn't pick a site near you, one of the benefits of this study is that there is a comprehensive travel program. Idera made a commitment to supporting the participation of all dermatomyositis patients in the study based on extensive feedback through TMA and its membership over the past few years as the study was developed. So to those of you who participated in surveys about travel, thank you so much for your contributions, as they really made this program possible. The goal of the travel program is to really address the unique needs that patients have, particularly when they're living with chronic disease and may have more financial burden or an inability to travel without a caregiver. So you'll notice that we've tried to achieve that by providing a travel program that supports a full and comprehensive ability to travel. We want all patients to be able to come to our study, regardless of where you live or your financial ability. The ability to participate should always be a decision that's reached by the patient and their physician. And we want to make the trial as easy as we can on patients. As Dr. Gruss covered, there are quite a few tests and doses that happen throughout the study, and we wanted travel to be a minimal concern for patients as they thought about participating. We elected to partner with a company called ClinCard. Some of you may be familiar with it, as it's used rather widely through clinical trials. And through the ClinCard, which is a fully funded debit card program used anywhere that MasterCard is accepted, you're able to receive reimbursement for reasonable expenses that are associated with travel in this study. They're listed out here for you, but include things like mileage, associated parking and tolls, public transit, meals and incidentals, and for those patients who are traveling from a farther distance away, 150 miles or more, there's a possibility of booking a hotel, airfare, or train. Those can be reimbursed for you or pre-booked as you participate to eliminate the out-of-pocket expense. It's a conversation between you and the primary investigator as far as the caregiver, but Idera is happy to provide medical travel support for medically necessary caregivers. You also have the option in this study to receive text and email reminders. This will cover your upcoming appointments and your reimbursements. It's an opt-in service that happens in the clinic, but it's designed to make it easier for you to keep track of your appointments that are coming up. The ClinCard program is provided at no fee for participants, and as I mentioned, you can use it as a debit card or you can use it to withdraw funds as well. So if you want to learn more about the study, you can contact Idera. Our information is here. The webinar recording today will also be available through the Myositis Association up at myositis.org. We have a clinical trials website, ideraclinicaltrials.com, that provides information consistent with what's on clinicaltrials.gov, but in an easier to read fashion. You're also able on that clinical trials website to download more information about the study, including a recap of frequently asked questions, an overview of the studies that Dr. Gruss provided, and more information about the travel program for participants. It is important to note that you should always discuss the study with your physician, particularly the enrollment criteria and current medication, and that, as Dr. Gruss mentioned, for screening, a copy of your complete medical records would be required, particularly if you're traveling into clinic. So I think at this point, we'll move on to Q&A that's available for us. So, so the first question we're going to take is, what is the purpose and design of Pioneer? So Dr. Gruss, I know that you spoke about this a little bit. I don't know if you want to give a more clarified answer about it.
So Pioneer is a phase 2 double-blind placebo-controlled trial. It's designed to determine if patients who have active skin and muscle disease on a fixed dose of standard of care therapy, if those patients treated with IMO 8400 have improvement in their skin disease as measured by the CDASI relative to placebo, as well as assessing the safety and tolerability of IMO 8400 in patients with dermatomyositis.
Great. We've received a question, once the study starts, do you continue taking your current medication? For example, if a patient is currently taking prednisone and methotrexate and they were to enroll in the study, what would happen to their medication?
Indeed, they will continue to take their prednisone and methotrexate throughout the study.
Great. We've received another question about what our hopes are in terms of treating skin and muscle. So I don't know if you wanted to run through perhaps the criteria for skin and the criteria for muscle in order to participate.
Oh, yes. So the CDASI score measures activity of the skin disease. It has 3 major categories of activity, which are the amount of redness, the amount of scale and crustiness, and then any erosions. And in addition, some very specific things that dermatomyositis patients can have, which are a lot of redness, blood vessel changes around their fingernails, and raised lesions on raised areas on their hands, as well as hair loss actually from their head. So if those total to a score on the CDASI of something called 15 or higher, then that's enough active skin disease for participation. It's a little hard to describe how much that would be clinically. If your doctor is familiar with performing the CDASI assessment in clinic, they might be able to tell you. If you're willing to describe the areas of skin involvement, either via phone or in any sort of pictorial format to the investigative site, if you're comfortable doing that, they could also perhaps give you an idea as to whether or not you have enough skin disease at rates of 15. The muscle disease is actually probably a lower bar than the skin disease. So there just needs to be any evidence of bilateral proximal weakness in your arms or legs or in your neck flexors as assessed by the study site investigator, and then just 1 of 4 other tests of abnormal muscle activity needs to be abnormal, either elevated enzymes or a recently done abnormal EMG or MRI or muscle biopsy.
Great. We've had a question about whether all participants will receive treatment with IMO 8400. So I know that you covered the setup of the study earlier. If you want to just review that again.
Yes. So this is a randomized controlled trial. So we're going to compare those patients on IMO 8400 to those patients who receive placebo. How this study is set up is there's 2 doses of IMO 8400 being tested. So if someone's randomized, they go to one of those 3 doses, placebo or one of the 2 doses of IMO 8400, which means overall for each patient there's a 2/3 chance of being randomized to receive IMO 8400 and a 1/3 chance to be randomized to receive placebo.
Okay, great. We've had a question just about the safety of the drug. So I was hoping, I know we flashed over this slide earlier, but just talk quickly in the other times that we've studied it, what we've seen that might be possibly related to treatment.
Yes, my apologies for not going over this slide in detail. So IMO 8400 has been tested in quite a few patients as of September, almost 100. So healthy volunteers, and the largest chunk of patients to date that have been tested were Waldenstrom's macroglobulinemia patients and then the psoriasis patients. For the most part, the administration of IMO 8400 has been generally well tolerated. one patient with Waldenstrom's maculoglobulopathy, and that's a form of lymphoma. It's a very slow-growing sort of lymphoma. The patient had a worsening of their arthritis such that they needed to discontinue study drug participation. Once they discontinued, their arthritis resolved, but they were no longer able to receive active study drug. In addition, the study drug was also studied in a more advanced lymphoma, something called diffuse large cell B-cell lymphoma. If any of you have ever had any friends or family who unfortunately have had cancers, often if they fail standard of care therapy, they may look to participate in a clinical trial. So that means that their cancer is often fairly advanced if they've participated in a clinical trial. And that's the case for these patients with diffuse large cell B-cell lymphoma. So while there have been no treatment-related deaths, there was a death of a patient that was deemed by the investigators related to progressive disease of their diffuse large cell B-cell lymphoma. Otherwise, what we know across all of these patients, the most common adverse reactions that we've seen with IMO 8400 include something called injection site reactions. So where the study drug is administered under the skin, patients may experience redness or swelling or some hardness around the injection or some tenderness or even some itching. We have not seen any breakdown of the skin, so blisters or ulcers. And then the other most common adverse reaction we've seen is patients may have a constellation of flu-like symptoms with fevers, chills, muscle aches, headaches. This often is transient and within the first couple days after the injection.
Great, thanks. So we've had a couple of questions come in about next steps to participate. So I'll take that and I'll flash back here to learn more. So the first question is about the webinar being recorded. It is, and our friends at the Myositis Association will be providing you with a link that you can share with friends and family members and also your care team to learn more about the topics that we've covered today. You'll also see up here to learn more. So if you're interested in connecting with a site for screening, the first step would be to review the inclusion and exclusion criteria that Dr. Gruss has mentioned. You can do that by requesting information from Idera. It's patientinfo@iderapharma.com. You're also able to click through any of the online links here and get more information about the study, or you can contact the Myositis Association. There's a folder of information available for patients that describes the inclusion and exclusion criteria in greater detail, and we're also, as a sponsor, happy to do that with you. You would then want to discuss the study as well as your current health and your medication list with your physician and make a determination if it's in your best interest to participate. If your physician is on board, you'll want to ask for a copy of your medical records that could be given to a participating clinical trial site. You can contact Idera for information about the closest clinical trial site near you. The map that you saw earlier is available online as well. We're happy to share information with you about the study coordinator for the site, as well as any information particular to the site that you may need to know, such as you should mail your medical records, they should be emailed to such and such a person, you'll need to get a medical record number ahead of time, etc. You'll then send your medical records over. That would be anything related to your dermatomyositis, as well as any testing that you may have had related to muscle or skin weakness. And as Dr. Gruss mentioned, any evidence of skin involvement will be reviewed by the primary investigator at the site. The site would contact you to set up the screening visit appointment. If you would travel related to that screening visit, you would be responsible for covering the travel out of pocket, but you would be able to be reimbursed for the travel related to that study. If you then became enrolled, you would be eligible to have your travel reimbursed, or depending on how far you're traveling, pre-booked for you. The study, as Dr. Gruss mentioned, also offers a home nursing option that's performed by a certified research nurse that's trained on the protocol and endorsed by the site. The nurse would go to your home on the intervening weeks to make the doses at home, and then you would need to attend the clinic, as Dr. Gruss mentioned, once every 4 weeks to receive your study dose at home. There is not any cost to you or your insurance company to participate in terms of the study medication or procedures or exams related to the study. It's important to check with your insurance company because any costs related to the standard care for your dermatomyositis, including a cost at the facility or a test that would be performed as standard of care, would be billed with your insurance. So it's just important to check with them and be sure that you have coverage, but worth noting that the only thing you would be billed for are things related to your standard of care treatment. And if you are unable at any point in time to connect with the study, clinical trial study site, Idera is here through our patient advocacy function to help support you. And I think that that's it for questions that we have that have come in online. So I'd like to thank you all for participating. As we mentioned, the webinar has been recorded and will be available through the Myositis Association, as well as the websites that you see here available for download and sharing. We're really thrilled to have received such a positive response from the myositis community, and in particular, the support we've received from TMA has truly made the development of the study possible. We're looking forward to hopefully sharing results with you soon. Thanks for calling in.